Hi, welcome. Good morning, good afternoon. We will let people continue to filter in. In the interest of time, since we do have a very full agenda today, we're going to go ahead and get started. Hello and welcome. My name is Dr. Heather White. I'm the Executive Director at Together for Health, and I'm pleased to join you to our ongoing webinar series where we host global experts on the topic of how to sustain and scale HPV screening and treatment programs across low and middle income countries, today's topic. A special thanks to our colleagues at Cepheid for co-hosting the event with us today. And before we begin, I just have a few housekeeping notes. Please note that all of our attendees are on mute. Following the presentations, we will have roughly 45 minutes of discussion. If you have a question for one of our panelists, please use the Q&A box and we will do our best to get to them. We do have pre-selected questions already that we will go through, but if you have a question, please do put it in the box and we'll try to get to it. The webinar is being recorded today, so it will be made available to anyone who is registered for the event. You can also find it on our website following the event. And if you're interested in learning more about this or similar topics, please let us know. We'll have our information at the end of the presentation today. Okay, on that note, let us get started. I am very pleased to introduce our first speaker, Dr. Maribel Almonte. She is a Peruvian cancer epidemiologist with extensive expertise on cervical cancer prevention research. She is the principal investigator of the ESTAMPA study evaluating techniques and strategies for HPV-based cervical cancer screening across Latin America. She also co-leads the CESTA study comparing HPV screen and treat with and without triage in Africa. In addition to her research, Dr. Almonte is based in the Department of Non-Communicable Diseases, Rehabilitation, and Disability at the World Health Organization, where she oversees the technical components of the WHO Cervical Cancer Elimination Initiative. Dr. Almonte also oversees the development of the WHO Cervical Screening and Treatment Guidelines and provides technical guidance and support to countries, towards cervical cancer elimination. Dr. Almonte will frame today's discussion around the WHO's Elimination Initiative, underscoring the importance of early detection and follow-up, and how cervical screen and treat models can drive forward progress towards the 2030 targets and beyond. And with that, over to you, Dr. Almonte.
Thank you very much, Heather. It is a pleasure for me to be here, and thank you very much for the opportunity to present to this wonderful audience. Next slide, please. So, and another click, please. And so we are here to talk about part of the Cervical Cancer Elimination Initiative, and we know that we have three main targets for 2030 that include vaccination, screening, and treatment. So we are aiming to get 70% coverage of screening with a high-performance test twice in life, and 90% of those women who are identified with either precancer or cervical cancer to receive treatment and adequate care. Next slide, please. So in WHO, we have different strategic actions to support countries to reach the two targets of the 70% coverage and the 90% treatment. Among them, there is, we think that we need to really work on understanding the barriers, improve the communication and the information that are given to women, to healthcare workers, to health facilities, and in general to the public, so that we can create an enabling environment for screening. We are very focused in promoting simple screening algorithms that can increase programs' efficiency and mainly support the follow-up and the completion of treatment and the screening continuum when we do screening. We also would like to ensure affordable supply of quality assured high-performance screening tests and treatment devices. Of course, we need to strengthen the laboratory and screening services capacity, and we also promote highly the integration of the screening and treatment services into primary care and other in-country health programs. To do this, over the last year, we've been working in a number of activities, among them what we call the living guidelines to update the current WHO cervical screening and treatment recommendations that were released in 2021, between 2021 and 2024. We also focus on developing target product profiles for HPV screening tests, and together with dialogues with the private sector that are producing HPV screening tests, aiming to actually facilitate the market shaping that we need to actually reach our targets. Next one, please. So when we talk about simplified screening and treatment algorithms, we are mainly referring to screen and treat and screen, triage, and treat. The difference, there is a difference between the general female population and women living with HIV, by which women living with HIV, for them, we only recommend to use algorithms that include triage. And also it is important to highlight that this triage component may differ between countries, between realities, between scenarios. Next, please. And I'm not going to go through all this slide, but just to let you know that there are differences again in the recommendations between women living with HIV and the general female population. Most of them, of the differences, are due to the lack of evidence in women living with HIV, but we are all, I think all the community is working towards getting additional information so that we can have similar recommendations. Nevertheless, it is important to highlight that we recommend high-performance HPV DNA tests as the primary screening test, either on provider or self-collected samples. There is a difference in age and in the interval of screening between the two groups. But in addition, for the general population, we were able to recommend high-performance mRNA tests only on provider-collected samples and only every other 5 years. As for triage, we suggest to use HPV limited genotyping, which involves results for HPV 16 and or 18, visual inspection, cytology, colposcopy, and in this year, we released a recommendation that we can use dual stain cytology as triage for HPV positive women. As for treatment, we want to actually ensure that the screening algorithms are simple, so we want to use, we suggest to use ablative treatment whenever eligible. And if a woman is not eligible, then actually proceed to referral for excision or additional treatment as needed. Next. So we know that technology evolves very fast, and many technologies are evolving every single day, and the evidence on their performance keeps accumulating. So we developed and we decided to go on through a living recommendations and systematic reviews process by which stakeholders do not have to wait 3 to 5 years to actually continue implementing something, improve the implementation of something, or implement an intervention that becomes obsolete. So we think that this living process actually may be more efficient to review the evidence at timely for what we need to offer countries. Next one. And everything that we do is based on our handbooks, just to say. In December 2022, the guideline development group of this living guidelines process met and highlighted 5 priorities: HPV extended genotyping, HPV testing on self-collected sample, screening and treatment techniques for women living with HIV, HPV point of cares, and artificial intelligence for the visualization of the cervix. Next. 18 or almost 24 months afterwards, we have had the second GDG meeting in person last September. We have produced and launched on the 18th of November the target product profiles for HPV screening tests, and we've had a second meeting on artificial intelligence image-based tools, just to look at the validation criteria that we need to evaluate the performance of these tools. Next. Just to summarize, in September, during the GDG of the Living Systematic Reviews, we went through the 5 topics, priorities from 2 years ago, and we highlighted potential new priorities like the follow-up of after a negative triage and after treatment and what the rescreening interval would be, novel molecular technologies, prophylactic vaccination to reduce recurrence after cervical precancer treatment, screening for vaccinating cohorts, and perhaps therapeutic HPV vaccines. Next one. But just to give you an example of what this means, these living systematic reviews, if we talk about HPV extended genotyping, the first thing we need to do when we go through this process is to define it properly. So here we propose that extended genotyping it involves getting the results, individual results for HPV-16 group with HPV-18 as in limited genotyping, and additional groups of results for 12 carcinogenic HPV types. As a difference, when we talk about full genotyping, we look at the individual results for each of the types that are included in a cocktail in a test. Next one. So these are just some of the formulations currently available for different tests for HPV genotyping. The colors denote the different groupings that exist. So just to let you know that this is what we will be looking at. Next one. In the event that we were able to recommend HPV extended genotyping, we're thinking of keeping as simple as possible our algorithms, and therefore having 4 categories: the negative that go to risk screen, the 16-18 positive that go to immediate treatment, and 2 middle groups for which countries will have to take a decision based on capacity, whether this second highly risk group will go to immediate treatment if the capacity to treat all of them is available, or will go to triage if the capacity to recall the negative triage people is possible, is there. And the same with the third group, or the less highly, if we can say that, risk, where they can go either to triage if there is a capacity for negative triage, or they can go to risk screen if we are super sure that we can give reassurance to women that they don't have disease if they test negative for the rest of the types. Next one. Next. Okay, so currently there are 264 HPV tests commercially available, but there is very limited information on how they perform in the real world. And the market, the manufacturing of HPV tests have changed over years, from having a lot of tests being manufactured in the US, as you see here in red, to now most of them being manufactured in Asia, particularly in China. Next. So we really need to have some sort of criteria to consider, to actually develop tests or manufacture tests that tend to support what we need to do in our elimination. And this is why we work on the WHO target product profiles that actually guide and coordinate this development of new products, considering from the starts the population, the access, and the equity. And also in our case for the elimination, what we want is that manufacturers really prioritize technologies that help countries reach the 70% screening coverage. We had a technical development group composed of 39 members with multiple expertise, and these target product profiles at the end, what they give us are 2 characteristics per a number of parameters: the minimal characteristic, or the lowest acceptable, and the preferred or ideal characteristic. Next one. So we decided, the technical development group decided to have 2 target profiles differently for laboratory use and point of care use, with 41 parameters across 8 domains highlighted here. Next. Just as a brief example, with respect to the samples to be collected, we decided that we really need to consider the test should be validated for biennial sample collection, either by women or by a health worker without speculum. When we talk about laboratory, we also give the option of having a cervical sample, as it's currently being done. But for future point of care tests, we really want to concentrate on vaginal samples. As preferred characteristic, we want both sets of tests to have the 3 possibilities. Next, there was a lot of discussion on what the genotyping spectrum will be for a performance test. So we tried to use the facts based on the current evidence and new evidence coming from IARC on the 12 HPV carcinogenic types. So the TTG agreed that these are the types that should be considered for future tests. Next. But somehow the question of can we use less balanced test, and based again on the facts and the evidence that we have, we decided as a minimal characteristic we can have the first or the high HPV carcinogenic types, but as the preferred characteristic, all tests should include 12 carcinogenic types. Next one. And then there was a question, can we use a point of care 16-18, which may be scale up fastly and we can offer treatment fastly? And the TDG decided that currently we don't have sufficient evidence to actually consider this. We still think that the minimal should be 8 carcinogenic types, but we are looking forward to have more information and more evidence on what the balance would be between an easy scalable lab test targeting only 16, 18, and a high performance test as we define them now that actually allows us to have a larger interval between screens. Next one. Finally, I just want to highlight that we also started the private sector dialogues for HPV screening tests. We have a couple of meetings, one with procurements and one with the private sector. And we decided that there were 5 areas to work: global access pricing, domestic pricing. We want the private sector to help streaming the procurement, quality assurance to ensure that anything that is put in countries really have the right quality assurance, and to support countries to demonstrate success. This is all based on the different challenges that countries are facing to start implementing HPV-based cervical screening. Next one. In summary, we know that technology evolves fast and innovations are the way to go. This is what we need to do. But we need a process such as the living recommendation to address the evidence that is accumulated in these new technologies. The living recommendations, as well as any recommendation or guideline, should be based on evidence on performance and the feasibility to be implemented and facilitate countries reaching the 70% target. There should be, when we do this process, there will be complementary work streams such as the TPPs or the dialogues or the pre-qualifications that we will also need to, strengthen to actually support the process of the living guidelines. And I think it is important to highlight, although I didn't touch a lot on my talk, a shift on focus towards implementation with strategic investments and coordinated stakeholder action is crucial if we want to reach the elimination goals. And this is going to be the topic of the next talks that follow me. Next. Just a big thanks to all of those that actually support us kindly with all the time and all the effort to develop all the work that we do at WHO. And we should remember that no one should be left behind. And that elimination cervical cancer is a commitment of all of us to make all women and girls to spare millions from the harms of a preventable cancer. Thank you.
Yeah, there we go. Thank you, Maribel. That was fantastic. And congratulations on the living guidelines. It's a great, I think, iteration and next step in helping to understand how to make sense of the technologies going forward. I just want to ask one question which came through the chat. It's actually from Dr. Pasoldan. She asked, what is the recommendation for follow-up of women who are HPV positive that receive ablative therapy? When do they come back for retesting?
Yeah, so the recommendation is that they come back after 24 months for, there are 2 things. There is a follow-up after 24 months to look if the treatment works. That's one thing. For women living with HIV, it's after 12 months because we think the risk of recurrence is higher among them. If after those 12 months, a woman doesn't have disease or evident disease, in principle, she should go back to the original screening interval, whichever has been taken by the country. But for women living with HIV, we recommend another 12 months to actually go for a second follow-up to make sure that there is no disease recurrence. So, but I have to say, Valerie, and for the whole audience, that this is one of the topics that we still have to work, and I put it as our new priorities, because when the guidelines were done originally between 2019 and 2021, we didn't have any evidence in this, because remember that countries were just starting HPV screening. Now that we have more evidence and there is a lot of programmatic data coming from different countries, we really need to revisit this question. What is really the time for follow-up, and what do we do at the follow-up? So currently we say you have to repeat the screening test that you did at entrance, but now we really need to focus on this. And it's not only about the treatment, those who received treatment, but those that were triage negative. When are we calling them back? Do we have sufficient evidence to say in 1 year, in 2 years, in 3 years? What is going to be that? So that's going to be part of the living guidelines, and we hope to have an updated recommendation in about 12 months. Thank you.
Fantastic. Thank you for that. Okay, great. Next, it is my pleasure to introduce Dr. Andrew Valley, who is the head of the Asia and Pacific Health Program at the Kirby Institute for Infection and Immunity in Society, Faculty of Medicine at the University of New South Wales in Sydney, Australia. He is a medically trained clinical epidemiologist with more than 30 years' experience living and working in low and middle income countries in sub-Saharan Africa, Asia, and the Pacific. Dr. Valley has an extensive portfolio of research excuse me, in sexual and reproductive health at the Papua New Guinea Institute of Medical Research in Goroka, where he was deputy director from 2010 to 2015 and led the world's first field trials of point-of-care HPV self-collection, testing, and treatment for cervical screening, known as the HPV STAT trial, and the first trial of antenatal point-of-care testing and treatment of sexually transmitted infections to improve birth outcomes, known as the WANTM trial. With in-country partners and colleagues at the University of Sydney, the Australian Centre for the Prevention of Cervical Cancer, and Family Planning Australia, Dr. Valley jointly leads the Eliminate Cervical Cancer Across the Western Pacific program, a world-first initiative that brings together landmark philanthropic, industry, government, and development partner investments to advance elimination in Papua New Guinea, Vanuatu, and the region. His presentation will focus on the work in Papua New Guinea and Vanuatu and share insights on lessons learned and the future for elimination efforts in the region. Over to you, Dr. Valley.
Thanks so much. I'm sorry about maybe I shouldn't have drafted such a long introduction. I'm going to talk a little bit today about our experiences from Papua New Guinea and Vanuatu, and just to note that it's coming up to, but it will soon be midnight here, and it will be even later in Sydney, and across in with our colleagues in the Pacific, be the early hours of the morning, and so unfortunately, my colleagues in country are unable to join us, but this presentation is really based on one that Dr. Paulus Reaper from Papua New Guinea, who's a tremendous colleague, mentor, and friend, he and I have given many times, and I'm really representing both Paulus and many others in the team, who you'll see in the photographs that follow, and really feel that I'm kind of standing on the shoulders of these particular giants who are really inspiration for our work. Next slide, please. I just want to start by giving a bit of context. So the area in red is priority area 2, priority area of work 2, within what's known as the EPIC program. And EPIC is our current major program, the Elimination Partnership in the Indo-Pacific for Cervical Cancer. And I'm one of the joint leads of this program with Karen Camphell, who I'm sure many of you will know very, very well, from the Daffodil Centre and University of Sydney, along with another professor, Deb Bateson, who also working very closely with Karen, and Marion Saville, who's the lead from the Australian Centre for the Prevention of Cervical Cancer, the ACPCC. And together, and with other colleagues, particularly Christine McCartney from the National Centre for Immunisation Research and Surveillance, NCIRS. We're leading a program of work that's probably best described with this framework, which I've put up. And I think this context is really important because the Screen and Treat initiative that we are leading and supporting in the Pacific and in Asia is taking place within a much broader context. And it's also taking place in a context of existing vision and enormous dedication and commitment from our in-country partners. We're not the ones, we're supporting a lot of work on the ground, but we're not the ones that really are the true visionaries and by any means the heroes here. The heroes here are people like Dr. Paulus Reaper from Papua New Guinea, Margaret Terehe, another leading gynecologist, and Dr. Boniface from Damatalau from Vanuatu, and many others who are really the key drivers and leaders of the program across the Pacific and in the countries where we work. And the reason I put this framework up is just, of course, to indicate that that across these various programs of work, these priority areas, and we, of course, are strengthening primary prevention through HPV vaccination and supporting our partners in taking their programs forward. And we have a very active, very strong program on secondary prevention, and that primarily is around HPV screening and treatment. That program includes laboratory strengthening, an electronic CanScreen digital registry platform, which is absolutely been a game changer in our work and our ability to help our partners in coordinating their work and providing real-time monitoring and evaluation. We also support cervical cancer treatment and palliative care, and are conducting, with Karen's leadership, policy and modeling support across all pillars of the elimination pathway in partner countries to provide them with that support to move forward and to take informed policy choices around their next steps in terms of developing robust and sustainable national programs. And the first program we started was called the Elimination of Cervical Cancer Across the Western Pacific, EQUIP, which was funded by a very generous philanthropic donation from Minderoo Foundation in Australia, and also a very generous support from Cepheid for the donation of goods and equipment and cartridges to allow PNG and Vanuatu to really establish and start their national programs, their screen and treat programs, and with subsequent funding allowing us to really build on that and help those first countries start to establish their national elimination programs for cervical cancer. The second program, EPIC, as I mentioned before, and the framework is shown here, that's funded through the Australian Department of Foreign Affairs and Trade. And we very recently secured additional funding through the Swire Group, which will, under the ADVANCE program, which is the Advancing Cervical Cancer Elimination in the Pacific. And that's really fits very neatly together into this EPIC framework, because the ADVANCE program is really very specific in looking to scale up screen and treat across the Pacific. And next slide, please. Keep trying to press my button to advance the slides. Under these initiatives, just to give you again a broad brushstroke, around 60,000 women will participate and be asked to participate in HPV screening and treatment in PNG and Vanuatu under the first program, EQUIP. Under EPIC, another 60,000 plus women will again participate in additional countries. And then we have this, with this new funding, which is primarily focused on screen and treat, that will allow additional countries to participate and allow us to add an additional 130,000 women. And with other funding, which are slightly smaller scale funding that's again complementary to this program of work, we'll be bringing together really more than $70 million worth of funding for countries in the Asia and Pacific, and being able to offer and provide HPV screening and treatment to over 250,000 women in our region, which is a really wonderful privilege to be able to support our partners in achieving their vision and supporting their incredible leadership. Next slide, please. So, okay, thank you. So I'd just like to focus on Papua New Guinea briefly. So as many of you will know, it's a country in the Pacific. It's the largest and the most populous nation in the Pacific. It's has cervical cancer, as they estimate, as the leading cause of cancer among women and the leading cause of cancer death, with significantly higher morbidity and mortality compared to Australia and New Zealand. Age-eligible women and girls are it's a very considerable population, a very considerable target that we have to reach, with over 700,000 girls for vaccination, 1.4 million age-eligible women for HPV screen and treat. But we have excellent in-country leadership and vision to establish a robust program. And we've been generating, together with our partners over the last 15 years, locally generated evidence that really has informed our thinking in Papua New Guinea and transformed the way in which we do our work. Next slide, please. So our program is based on what we call point of care HPV screen and treat. Others would say it's near patient care rather than true point of care. But we provide a same day service within the clinic itself, using the GeneXpert, the Cepheid platform that's actually set up in the clinic. Women are asked to provide a self-collected vaginal specimen, which we test on the Cepheid platform there and then in the clinic. We're able to provide those results typically within 1 to 2 hours. I mean, the test itself, of course, only takes an hour, but depending on the number of women that are attending the clinic, it may take a little longer. Oh, sorry, you jumped back a bit. Sorry. and and then those that test positive for any of the HPV types of the 14 types that are detected through the using the Cepheid platform are offered visual assessment to assess eligibility for same-day treatment, and then either provided thermal ablation there and then, or referred if there's if the transformation zone suggests that same-day treatment is not possible, or there's any suspicion of a lesion, and that specialist review is required. So it's an entirely nurse-led service, and critically, the information we collect is entered into the CanScreen register the same day, and this provides a really fabulous resource, as I'll go on to show you in a second. Next slide, please. The program and the is really based on, sorry, you can go, I don't know, the slides are jumping around a little bit. Go back a little bit. Sorry, next one. They're doing something rather strange. The HPV, I think you'll get the idea. Anyway, for the study, we summarized 2 large-scale field trials, and in particular, the HPV STAT trial, which in the Lancet Global Health recently. And this was the first time that a same-day, fully integrated HPV screen and treat approach had been implemented in any setting, and we demonstrated the performance, the clinical performance of this approach, and showed that it was safe and it was effective. And this was really a turning point in terms of our discussions in country, and in terms of the ability for us as a group to really support partners in moving towards policy development around a change towards primary HPV screening. Next slide, please. We also showed with Karen's working with Karen's team that this was a highly cost-effective approach compared to visual inspection with acetic acid alone, which is what we've been using before in Papua New Guinea. Next slide, please. And that this was highly acceptable to women and to health workers providing that service. Next slide, please. So the program in December 2021, we had these data first became available. The final data from the trial became available, and fortuitously around the same time, there was these wonderful guidelines that were provided by and produced by WHO for screening and treatment of cervical precancer, and we were readily able to take those proposed algorithms and flowcharts forward, and to also utilize the data that we had from Papua New Guinea, and to utilize and think about the specific contents of Papua New Guinea to make some adjustments to that algorithm and to make it fit for the specific context there. So this was really, really fantastic in this combination of the new global guidelines and the local level research evidence to really drive this change in policy. And this happened in December 2021. Next slide, please. And following on from them, we've moved forward with our work and with establishing a program in Western Highlands, firstly under the EQUIP program, with a provincial hub established at a Well Women's Centre in Mount Hagen, which is at the centre of Western Highlands province in Papua New Guinea, and then from there conducting rural outreach. Next slide, please. Sorry, can you go? That's it. So we've seen an unprecedented response with the rural outreach. That outreach has been conducted using a mobile clinic van that was purpose built, and we was previously on site. We refitted the van, and so that we could provide HPV testing in the community. This province has quite a relatively good road network. It means that we can get out to peripheral centres, and we found that there was really a huge demand for services. And of the roughly 25,000 women plus screened to date in Western Highlands, around half have been screened through the mobile outreach and around half through the fixed facility, health facility located in the provincial capital. Next slide, please. That is really jumping around like crazy for some reason.
Yeah, apologies for that. For some reason, it just keeps jumping on its own. We'll try to get it
Yeah.
sorted. Just
It doesn't on my screen, so I'm not quite sure why it's something lost in it. Sorry, I have to go back up again. Sorry. Okay, next. Try next slide. That's a. Oh. Yeah, it really is all over the place. Oh, yeah, okay.
sorry for the difficulties. Let's see.
That's still a long way off where it should be. I mean, I can share my screen if that would be easier. That's it. That's the one. Okay. So today, we've now the program has now shifted focus somewhat and continued with the commitment to HPV-based screening and treatment. Continued with its commitment, of course, to the management of pre-invasive and invasive disease, but also managed to start and to roll out a very robust and the country's first really robust HPV vaccination program. We're now seeing to date over 20% vaccination coverage already. Our screening coverage at the population level is reaching 80%. And the team, and I think this is through their real commitment to the point of care, same day screen and treat by taking all elements of the service out to the community, have been very successful in achieving the 90% target for the management of pre-invasive disease, and very successfully been able to ensure treatment, the follow-up, for women with invasive disease, so they are also appropriately managed. Next slide, please. I'm not sure where it will stop and try and make that. So just to say that the program, this has led to a successful introduction in both New Ireland province there, which is jumping fast.
Oh, sorry. Yeah.
Southern Highlands province as well. And if we maybe, it's very strange why it's doing that. Probably it's on an Apple Mac. The original one was developed, so maybe. So it doesn't do it on my computer.
Yeah,
So
yeah, I'm not sure
Yeah.
if it's possible to talk through the remaining slides and without seeing them, but we'll follow your lead.
Yeah, no worries. So it was really just to say that in New Ireland province, we were successfully able to get started in that province this year. Also, and that on the panel, a picture on the right is Palace Reaper, who's holding the mask on the left there, and Dr. Stannard Iosiri, who's the Chief Executive Officer for New Ireland Provincial Health Authority on the right in that picture, both of whom are incredible leaders in country. And really have that vision to drive the program forward, which has been absolutely fabulous. Next slide, please, if we can. So, or maybe we'll just try and see if we can get to stop on some. You want me to just try and share my slides?
Well, I'm just a bit concerned. Just one second. Megan, would you like to? Yeah, Dr. Valley, you're welcome to try to share your slides. I just am watching the time and want to make sure we've got enough time for Q&A.
All right.
Let's see.
Okay. Okay, hang on a second. One sec. How's that? Are you seeing which slide are you seeing?
We can see it. It's on the it's on it's not on the presenter view yet. It's we can see like both slides.
It was the previous slide, which we can see now.
Mhm.
That's the biggest.
You can see the big one now, or the other one?
No,
Is it full?
it's not in presentation mode now.
So it's a full screen slide, is that right?
No, it's not in presentation mode, it's in presenter mode, so we can see two screens, the existing slide and the upcoming slide.
Okay, I'll try one more time. Is that better?
Yeah, that's it. Thank you.
That's the one. Okay. Okay, so I think we did talk about that one. I'm so sorry about this. And also we've been moving forward with Southern Highlands province and a couple of other provinces in PNG. That meant that we now have over 35,000 women screened. This slide, this total was a screen grab from earlier at the end of October, but now it's more like 35,000 women that have been screened. And we have real-time data. We can look at the proportion of those that are positive. We can look at the HPV test results. We can look at a breakdown by age. We can also look at a breakdown by a geographical location. And this platform has really been, as I say, a game changer in the way in which we've introduced and supported programs, so we can see key areas that are underserved. We can target the mobile outreach to address those underserved areas, and we can see the map. It's been a fantastic policy advocacy tool as well, because we can see as new sites come on board and the screening continues, that the map and the mapping colors start to change, and that's been a very powerful way of representing the program as it rolls out. We still have a long way to go, of course, because nationally our coverage targets our biggest success has been in Western Highlands province, and a number of provinces are just shown as they come on board, but nationally we still have a long way to go. Moving now to Vanuatu. Vanuatu, we are supporting a national level program. That the target here is around 30,000 or 34,000 age eligible women for screening and around 20,000 age eligible girls. And we are supporting a program that is starting to really see some significant impact, with over 20% of girls vaccinated, around 38%, nearly 40% now, women have received an HPV test, and treatment coverage has been high, but still not quite the level that we would require, and but very it's fabulous at 80%, but we're all striving to try and push that up to the 90% target. Similar hub and spoke model, very different geography, very difficult geography, with enormous number of islands and communities scattered across a very wide areas. We've set up two hubs, one in Cepheid province, one in the capital in the south of this, in the lower part of this picture, one in Luganville in Sanmar province in the north, from which we've done, or the team have done, outreach activities. Outreach there primarily by ship, small boats, charter planes, and so on. And the team, again, incredibly dedicated and resourceful team that have really moved heaven and earth to get to some of these communities, that some of which are incredibly remote. And again, we can see with the counter screen register how the program has proceeded, and where the areas where we still need to, which here are yellow, the areas that where we still need to ensure the outreach team are able to reach. So in the remaining few minutes, and I've just got a couple of slides now, just think about key challenges. So some of those key challenges around ensuring and maintaining the quality of clinical and diagnostic components of the model as the scale-up proceeds. It has been a significant challenge reaching women in rural and remote communities, and it's been particularly challenging across all settings, achieving high rates of clinical follow-up at 12 months among women who are HPV positive and receive thermal ablation at first visit. I think there's got to be many people feel, and I think it's perhaps got to be said, that the hardest part of the 90-70-90 is the final 90, with achieving effective, efficient, and appropriate referral of women with invasive disease, ensuring we have access to histopathology, diagnostic radiology, as well as surgery and chemoradiotherapy and palliative care. All of these aspects we are working on within the program, and working very, very closely with our partners to strengthen those services. Sustainability, service integration, and of course, longer term financing and funding are absolutely critical and remain very much key challenges. We've learned that of course, local leadership and champions are absolutely essential. We've only really worked all those countries I mentioned, we're only working with because people there took the leadership and took the initiative and came to us and said, we'd like to do what you're doing in Papua New Guinea. We'd like to work with you. We'd like your support. And it's their vision and leadership that we're supporting here. I think the willingness to take evidence-informed risks with implementation, even if it means some of you may be familiar with the term from participatory learning and action around failing forward. Being able to say that within a program with very robust monitoring and evaluation, to be able to pilot things that where there is some risk that it may not actually work as well as you think, but that you have sufficient monitoring and evaluation in place that you're able to very rapidly change direction if need be. And I think that's certainly been our experience with the mobile outreach in Western Highlands province, where we've seen that's been a huge success, and to be honest, much more than I'd kind of really imagined. I was personally quite cautious about that approach. And then the counter experience was really with both in PNG and in Vanuatu, where teams have gone out into very remote communities, asked women to self-collect specimens and bring them back to a central location for testing, and then subsequently gone back both to provide results and also to do examinations and treatment for those women who test positive. And the problem with that approach has been achieving the high coverage for treatment and effective management. And we've certainly seen that in a number of settings, and that led to a slight change in direction in the way in which those programs and their outreach operates. We've seen the importance of real-time implementation, evidence, monitoring, evaluation, and program support through CAN-SCREEN in particular. And that's, as I've said a couple of times during this talk, been really essential in terms of informing what we do and the way in which the programs are implemented. It's really important to, of course, to strengthen the broader health systems and to consider the wider context in which the programs are introduced and sustained and implemented. One reason I think many of us feel that the programs have been so welcomed, have been so successful in PNG and Vanuatu is because they have been delivered within a broader program of work that's very much understood by health workers and of course by the policy makers and decision makers, and also by communities and those that are engaged in the program. And final lessons learned really that certainly, as I mentioned, a trade-off between what we call the same day HPV screen and treat versus this kind of modified approach where we go out, collect the samples, and then go back later into rural communities. We've seen that the excitingly HPV screen and treat has really acted as a foundation for the introduction of HPV vaccination. I think in a country where there was enormous hesitancy and great problems with COVID vaccine, and where we've struggled for many years to achieve high coverage under EPI, we have been so far very successful in Western Highlands in the introduction of the HPV vaccine there, and it's partly been because women and community members and community leaders have been coming to us during the mobile outreach for screening and asking, when are you coming with the vaccine, so that our girls are less at risk and won't require the same amount of screening and treatment that our women currently do. And so it's really changed the dynamics around introducing the vaccine in that context, and it's allowed us to also pilot integrated strategies for implementation. And we're now looking at integrating and both because we believe integration is what we should be doing, and we shouldn't have a siloed approach, integrating screen and treat with the management of other non-communicable disease and cancer screening. But also we believe this may be a key, or one of the keys, towards future sustainability. And finally, I just want to I won't obviously thank everybody by name, but just really want to thank that leadership, particularly the Papua New Guinea Obstetrics and Gynecology Society, who were the first ones to come to us at the Papua New Guinea Institute of Medical Research and say, we have a problem with our PAP test program, it's not working, what can we do to help? And then to go on this journey with us over the last 15 years, exploring VIA alone, VIA plus HPV, HPV with different triage, and now point of care, same day HPV screen and treat. I'll leave you with our final slide from the Vanuatu launch recently, which was a real pleasure. And thank you all very much. And sorry about the slide and running over time.
Thank you so much, Dr. Valley. We appreciate the perspective. And I'll ask the other panelists to turn their cameras on and do a quick round of introductions of everyone before we can get to questions. First, I'll introduce Tracy Schisler, who is a project director with Jhpiego and global health project strategist with over 20 years of experience. Tracy currently leads Jhpiego's technical and program strategies, scope, and implementation research as a partner on the UNAID-funded Success Project and is part of Jhpiego's larger Women Cancers unit. Dr. Håkon Beltman is a gynecologist-oncologist at Leiden University Medical Center. He is also a board member of the Female Cancer Foundation, a nonprofit focusing on secondary prevention of cervical cancer in low-income settings. Recently, he was involved in the Prescript Tech Consortium that introduced HPV testing in combination with AI in 3 low-resource countries. Dr. Valerie Paz-Soldan is a Peruvian-American social scientist based permanently in Peru as the director of Tulane's Health Office for Latin America. Her current research is in HPV and cervical cancer, which led to the design and implementation of new HPV-based screening and treatment approach in Iquitos, Peru, that is now being scaled up at the national level with her team providing technical assistance in the region. And Professor Nelly Mugo is an associate research professor in the Department of Global Health at the University of Washington and a senior principal clinical research scientist at the Kenya Medical Research Institute, or KEMRI, a reproductive health specialist with over 3 decades of work experience. She is a co-investigator on a number of landmark clinical trials, including the PrEP trial and the Kinshi study, and is widely published in peer-reviewed journals. And she is a member of the International Papillomavirus Society Education Committee and the Kenya Obstetrics and Gynecology Society. So thank you to each of you, very extensive resumes and CVs and background. Let's dive right into questions. I'll actually start off with Tracy, if you don't mind. Tracy, given Dr. Valley's presentation and sharing really about what it takes to do the implementation research and working within the community context, I'd love to hear your thoughts on how the screen and treat models were particularly challenging and were successful within the Success trial, and what your key takeaways were within the Success project.
Thanks so much, Heather. And yes, I like following Andrew's presentation, given some of the fail forwards also that we experienced or learned from in observing countries increasing their scale up. I'm going to comment on 3, and I'm highlighting things that weren't as talked about in the prior presentations, just to add to some of the diversity of points. I want to emphasize planning for precancerous treatment up front as being as important as planning for screening. I think, we've learned and we know screening introduction is a health systems integration exercise. And so much goes into that screening piece. We plan for downstaging screening to more accessible facilities. We plan for working with community-based organizations and community health workers. We plan on the nitty-gritty, so moving samples to labs and preparing labs for higher volumes and getting results back. We plan for procurement and expiry dates, like all the things. And I think when we look at the large screening goals, it's easy at first to look at the comparatively lower precancerous treatment needs And it might look so manageable compared to the screening and testing numbers. And the nature of a project like Success and similar projects means that we procured everything up front. We expanded training on thermal ablation. We set up the data systems. But what we're seeing as countries expand HPV screening, that treatment is not keeping up in all cases. And the attention turns to it when there are delays to treatment or losses to follow-up increases. I was just in a country last month where a local government municipality was buying 20,000 HPV sample collection kits and test kits, which is tremendous. It's the first that they're buying, but they didn't budget thermal ablative devices. And they have 3 that are from Success. So it's one of those circumstances where there are external parties there, including ourselves, to help supplement with devices and training. But it's something that it's not the first time we've seen this, and it really risks the women who are confirmed to need precancerous treatment. A second point is counseling. We know fear and stigma are complex within cervical cancer, and the quality of counseling is really important to educate and address women's concerns. And once we add HPV testing to cervical cancer prevention, it makes the counseling even more important. Often it's not counseling for a single visit approach, it's counseling for self-collection, potentially testing positive, that there's at least one more facility visit if positive, often 2. And we've been adjusting for this where we work and intensifying counseling, but it also means that we need to really think about this upfront and prepare women for that. We're looking at this more in our phase 2 qualitative research to be able to better capture how that is for women. But for both of these examples, I just want to note that the point of care tests that are in the pipeline could be game changers to minimize screening to treatment times. And just one final point on continuity of screening and care. Continuity means working really closely with the country cancer and reproductive health leads in their costing to scale up and creating multi-year operational plans that include budgeting. This is a big change from BIA. So we found that sharing product information, Jhpiego and Unitaid have put together some great tools and resources over the years, and getting those in the hands of those making the decisions and helping them to better understand their options in terms and pricing and calculating their numbers to reach their 2030 and beyond goals.
Thank you, Tracy. I appreciate those insights. And you touched on both, the importance of the care continuum and ensuring that you've got timely access to not only pre-cancer treatment, but of course, further along the continuum, and then what it means from a behavioral perspective. I'm going to ask both Dr. Beltman and Dr. Paz-Soldan to chime in on these points and make any additional notes. First, to you, Dr. Beltman, as a gynecologic oncologist, where do you see opportunities using a screen and treat model to be able to shore up those the initial treatment or even moving down the care continuum? I would love your thoughts. And then we'll turn it over to you, Dr. Paz-Soldan, to talk a little bit about sort of social behavioral change and where you see opportunities around not only messaging, but also from the social science perspective, messaging and behaviors needed to really shore up care along the continuum.
All right, thank you very much. I think it's extremely important that women, once screened, continue the rest of care. And actually in our study, we saw a relative decline in VIA uptake, which was done in health facilities after HPV self-testing, which was usually done in households. A little bit maybe about our project, the Prescript Tech project, which started in 2021. We included 4 countries, Bangladesh, Uganda, India, and Slovakia. And after community mobilization, we did HPV self-testing. And once the women were tested HPV positive, they were referred to health facilities for further follow-up, and we use also AI decisional support system to improve quality of diagnosis. And we also did direct treatment in case of lesions, or we referred these patients in case of, well, the lesions were not eligible for treatment or were suspicious for invasive cancer. And what we saw was actually that over 88% women accepted HPV self-test, so the uptake was really high. If we looked at the VIA uptake of HPV positive women, we see a little bit of decline, so an average of 70-75%. And then if we look at the treatment uptake after VIA, then it varies a little bit between countries, but then we saw over 90% uptake of treatment. So that's important. I think to add to that, I think it's important to mention what also supported in our study to the high uptake of treatment after HPV testing is the use of the electronic medical record. So by storing all data in one system with one coordinator, we had better insight to those who needed treatment, so we could also trace these women. Also, I think which is very important is the community workers. They receive a lot of trust within the community, so they know where women are, they know how to reach them, they know their availability. And it's also important to mention that many women do not have always good experiences with hospitals. Another thing we found, especially also in Uganda, was that if you make a designated or a fixed day in a facility where women come who come for screening have a priority with a dedicated team, that limits not only waiting time but also increase patient satisfaction. So that's, I think, also very important. And at many sites, I think cervical cancer screening is usually an extra task. So it's an add-on on top of many other tasks. So if you can change this a little bit, I think that would help this continuum of care much. Thank you.
Thank you, Dr. Beltman. Great points. I think particularly around, the trust that is engendered with local frontline health workers, navigators, and so on. I think that's a key point. I'm going to turn it over to you, Dr. Paz-Soldan, for any additional thoughts on behaviors and from the social science perspective, or anything you'd like to comment on. Thank you.
Thank you. I think when we think of the social science individual behaviors, we start thinking about like women are not coming, the midwives are not doing a specific activity, and you can think of models like the capability, opportunities, motivation. Is it an issue of capacity that they don't know how to do this, or they don't know about something? Is it an issue of opportunity? Do they not have the supplies available to do what they're expected to do? So I think we need to move from thinking of the individual behaviors to thinking about the system behaviors, which is what Dr. Beltman is also referring to, because all of it has to work well for it to function well. If you give the opportunity and women are able to access the health services and go to obtain their HPV testing, and there's no HPV testing that day because the procurement has failed, then they lose trust in that system. And so all of your work has gone to nothing. So I think one thing that I'd like to emphasize is, working with my colleague, Dr. Patty Gravitt, who taught me the importance of sharing mental models with system players, to emphasize that, everybody was focused on screening. They were focused on screening women and why women weren't coming. And indeed, the screen and treat model reduces barriers because there's less time, means less barriers, less bureaucracies, less money that women have to spend coming back and forth. But it's also important for all the system players, the health authorities and professionals, to understand that screening is not important if you don't have any treatment to follow up with. And that's what really struck me about Dr. Valley's presentation, is like how they were able to get to that 90% treatment. And the other one is using simple scenarios to understand what would happen in a system if I change this part of the system, what would be the impact on the system. So I think there are different strategies we can conduct with different system players that help us understand the system better, and not just at the individual level, but at the system level. And as an example for success, also is being able to pilot different strategies, show the system how it can be done, and then allow them to take the lead in moving it forward. Recently, we piloted this screen and treat approach in Iquitos, and it has led to a scale up throughout the country. And we've also tested putting a Cepheid gene expert on a ship on an Amazon river. The director of this program saw that we were able to screen 233 women, treat them that same day. And the 35 women who were positive for HPV, 32 were treated with ablative therapy. 2 had already returned to their communities. 1 had cancer and has since passed away. But yesterday I found out that 12 new Cepheid machines have been purchased for more ships because they saw that it could be done. They were inspired that you can do screen and treat in the same day. So I think part of it is understanding that system, showing how it can be done, and then letting others take that movement forward. Thank you. Sorry about my cough.
Yeah, no, thank you. Those were really excellent points, and I really appreciate that perspective around systems thinking and adjusting and tinkering with the system itself. My mentor, Dr. Grossbeck Parham, will often say, you could put the best technology in a failing system and you will come out with a failing outcome, or a less than perfect outcome for sure. So I think that's a really important perspective. Dr. Mugo, I'd like to turn it over to you and hear your perspective and thoughts, both as a clinical research scientist, but also working as a KEMRI representative. And I'm thinking about the policy landscape, but I would love to hear your thoughts about, how does from a country system perspective, how does one start to discern and think about what sort of models would be the most effective, and what does it mean in terms of putting those together from a policy and an implementation perspective? It looks like you're there. We go.
So thank you very much. It's been a real pleasure to listen to all my colleagues and hear their perspectives, because I think we have very similar experiences, especially the things that Valerie and Andrew have spoken to. So in Kenya, I think similar to many LMICs, cervical cancer is still, the leading cause of cancer death amongst women. Our awareness rates are about 40 to 50%. So we're still not there in awareness amongst the women. And I think we also heard about stigma, cervical cancer stigma and what happens when people have diagnosis. So we launched the HPV vaccine in 2019 and had low uptake of 33%. Now with the school program that went up. On the policy platform from the 2021 guidelines, we've always had visual inspection with acetic acid. We now said when available, we can have HPV testing for screening. And the CHI program was piloted in Kenya. And self-testing uptake was high, but they still had problems with completion rates, with still those access. So in the absence of the same-day screen and treat, uptake of treatment completion rates were not very high. And they turned out to be similar to what has been documented previously, that our treatment uptakes have only been up to 30% of screen positive. So I think a previous speaker also said, I think it's Valerie who just told us, that screening without access to treatment is really problematic. I'm working, so our policy platform, and we have a national cancer program, which has actively been working in this space. But what they've really pushed is VIA, because that's what's available. And HPV test has proven to be really expensive on that level, even with the Cepheid. And with the Cepheid Gene Expert platform, where I have worked, we found this competitiveness because they're clear that the platform was purchased for VIA. TB takes priority. So getting the lab to do for you the same day screen and treat, screening for HPV is difficult. So when I had Andrew talk about setting up the equipment in the reproductive health facility, I think that's a model. That's what testing. I think what Valerie's spoken to, putting the equipment on the ship is what has allowed the same day screen and treat using HPV. My experience, and I think the experience across board, is that while VIA testing has been said to be cheap and easy, it really isn't. You know, we've been evaluating it because I have an R01 looking at how to increase screening uptake using thermoablation. Now, we found that healthcare providers actually learn thermoablation and they like it and they're able to do the nursing cadre. But VIA is not as simple to learn because it's a very qualitative evaluation. You need to do a substantial number, and then to actually maintain proficiency, then you need supervision visits, which are missing because that need another layer of investment and resource. And actually across board, everywhere I've seen, nobody has moved to significant screening uptake with visual inspection. Our Kenyan rates are still around 16%. So when Chai did the self-sampling with HPV, so uptakes increased. And the national program has purchased quite a number of thermoablation equipment in the places where I'm doing my research. But the problem has been the screening piece. And where PEPFAR has purchased HPV testing, then they run out and they're not able to sustain them. And I think there are several things we still haven't figured out on the implementation level. And then I'll stop soon because I can continue talking for a long time, is that what my experience has been is that we go into the facilities, to the nursing cadre, who we say these are their tools to deliver. But then you have to work through the system. So for me, it was very interesting to listen to Andrew, because you can see from the photos, their program has everybody on board, and they have the validation of every level of leadership to support the healthcare provider. But when you go and you train the nursing cadre in the program, but the whole system in the facility has not embodied it, it doesn't become a priority. So if people are asking, how much screening have you done? Is that your priority at your family planning clinic? What is the reporting system? Who gives feedback? So what if you screen or don't screen? So we find most facilities who screen may screen 1 a day, 2 a day, and that there's a lot of turnover of the staff who do screening. So at any one point, if you're looking for somebody who's been trained, you may find them move to another area. So that whole program orientation, and I think through the system, I think the system issue is big, making sure that every level of the system is embodied into ensuring and providing oversight to ensure that screening and treatment is taking place. But our current experience is that once you've trained the nurses on screening, they have thermoablation, they treat the screen positives. That really works. That the Gene Expert equipment is excellent, but it's not accessible in the current model where it's sitting in the lab, and it's difficult to do a screen and test with that platform. But the national level, the policy level, has opened up the space. So that's continuously working. And the final one, challenge, is that the women who screen positive are not eligible for ablative therapy. Now, getting them into excision is problematic. Having them access. So it's really frustrating that the women with the large lesions and endocervical lesions who are at highest risk of disease then have the highest burden of knowing this and not being able to access the excision treatment. I don't know if I've answered everything that you wanted me to. So, I mean,
Very
which is
well.
moving from policy to implementation. Yes, there's a valley that we need to find how to close.
Well, we could certainly keep the conversation going for probably the next hour or two. We are already at time, which is unfortunate because I have to say, Professor Mugo, you brought up so many great perspectives and points. And I think to your point and to Dr. Valley's earlier point, the treatment pillar really is a real and persistent challenge, and we owe it to everyone that we serve within the context of these programs and communities to keep chipping away at what are the best practices and what are the strategies that will work. I would just like to say thank you to everyone who's joined today. Thank you to all of our participants and panelists. Thank you to the Cepheid team for co-hosting with us today and for everyone who was able to spend time with us. Apologies for the technological difficulties. We'll certainly make sure that you've got the slides and the presentation recorded following the meeting today. Thank you again, everyone, and take care. We'll see you next time. Thanks so
Thank
much.
Thank you.
Bye-bye.
Bye.
Bye-bye.